So this is a webinar based on a toolkit that was developed for Thrive NYC, which is the New York City mental health office. And Ramona had reached out and asked if I would do a webinar on the toolkit and pandemic mental health for faith leaders in general. So I certainly appreciate the invitation. I have been down to Fairfax a few times to lead disaster chaplaincy trainings along with two of my other colleagues, Ruth Yoder Wenger and Fred Mead. So I may have met some of you in the past, and it's great to be with you again. So again, hopefully you're familiar with Zoom at this point, but if you're not, please ask Susan any questions. Try to keep your microphone muted. It seems like everybody has that set up right now. Use the raise hand function if you'd like to ask questions, and hopefully technologically will go easy for all of us. If you find that anything is not working, like you're not hearing sound or the slides are behind you or something like that, please let Susan know. So my name is Peter Goditis. I am the Executive Director of New York Disaster Interface Services here in New York, and I also serve as the President of the National Disaster Interfaith Network. And I do quite a bit of disaster spiritual care and disaster mental health training nationally. I'm joined by two colleagues from the NIDIS office in New York, Gabrielle Sclafani, who's the program manager for our Faith Sector Community Preparedness Program, which is funded by the New York City Department of Health and Mental Hygiene, and this toolkit project, which was funded by the Mayor's Office of Thrive NYC, and Susan Polewski, who is our COVID-19 program coordinator. And it would be helpful, I think, if we just hear from each of you, your name, your role, title, position, whatever the right term is, and your congregation or organization. And because everybody's face appears differently on everybody's screen, and order won't be clear, I'm just going to call you out, and hopefully you can introduce yourself, and we'll get through the list that way. So the first person under me is Howard Butler.
Yeah, I'm the pastor of Peace Baptist Church in Donelon. I'm also a chaplain.
Great, thank
Fairfax
you.
County.
Thank you. And Paula?
Good morning. I am a volunteer system chaplain with Prince William County Department of Fire and Rescue in Manassas, Virginia.
Thank you. Beth Goss.
Hello, I'm glad to see some familiar faces. I'm Reverend Beth Goss, retired Presbyterian minister, but I'm still active with Fairfax County Community Chaplains and Presbyterian Disaster Assistance.
You sound very happy about that retired title. Reverend Missy Holt.
Good morning, everyone. I'm Reverend Missy Holt. I am a member of Mount Pleasant Baptist Church in Herndon, Virginia, and I am an ordained minister there and a Fairfax County chaplain.
Thank you. Marlene McCabe.
I'm Marlene McCabe, and I am a lay pastoral caregiver for Bohick Church in Northern Virginia.
Great. And Ramona.
Hi, everybody. It's so nice to see you all. I'm Ramona Carroll. I'm the, interfaith coordinator and community impact manager with Neighborhood and Community Services. And thank you all for, Peter and team, for coming and presenting us with this information. We're truly grateful.
Thank you. Jerry Foltz.
Good morning. I'm Jerry Foltz. I'm a retired United Church of Christ pastor emeritus at Wellspring United Church of Christ in Centerville, Virginia. I've been a volunteer chaplain for the Fairfax County Fire and Rescue for over 20 years. And I'm also a coordinator for our regional body for our National Disaster Ministries Network, United Church of Christ.
Thank you. Brennan Hanfield.
Hi, good morning. I am Bishop of the Kingstown Ward for the Church of Jesus Christ of Latter-day Saints here in Alexandria, Virginia.
Wonderful. And the name is sort of cut off, but it says New Creation AM.
I'm having technical difficulties. My name is Jane Wilson, and I'm a member of New Creation AME Church, and I'm also a member of the Fairfax County Chaplaincy Program.
Wonderful. Thank you. Brian Perry.
Hi, good morning. I am an Elders Quorum president in the Alexandria First Ward of the Church of Jesus Christ of Latter-day Saints in Alexandria.
Thank you. Sally Hoover.
I'm a deacon at Church of the Epiphany Anglican and a Fairfax County chaplain.
Thank you, Sally. And last but not least, Carolyn Rankin.
Yes, hi everybody, good to see the chaplains. My name is Caroline Rankin. I work with Neighborhood and Community Services here in Fairfax County, Virginia, and I work in the Community Impact Unit, and I'm support staff for the Faith Communities in Action and specifically for the Community Chaplain Corps.
Wonderful. Did I miss anyone? I don't think so. Okay, thank you. Whoop. So this is going to be part presentation and then facilitated discussion. I certainly want everybody to feel free to share whatever it is that's on your mind. I don't want anybody stressing out over questions. There are no dumb questions. I think it's important to also note that given how the pandemic has affected the United States and the global community, everyone's relationship to it is quite different. We've all experienced different things in our families and in our ministries. So I want to name the fact that everybody's experience is unique. So you should feel free to share from your own personal experience. And I hope that you all will feel free to chime in whenever you feel like you'd like to mention something or ask a question. So this toolkit, again, was developed for faith leaders originally in New York City, of all faith traditions, to help faith leaders better understand pandemic mental health challenges that not only face our congregations and the public, but that also face us as caregivers. Whether we are in active ministry in a congregation or a chaplain in an institutional setting or leading a denomination network of congregations or an entire denomination geographically, there is an enormous amount of anxiety in the United States about the pandemic. It's palpable. It's all over social media every day, where we all know never to get any accurate information, I hope, because it's pebbled with so much commentary, it just stresses you out to read it. So we also are facing the reality of a great deal of grief in the United States over the tremendous loss of life. So we are quickly approaching 500,000 fatalities related to the pandemic. And that, of course, means most communities in the United States have known loss, and many families. I was on a Zoom call yesterday with some Muslim leaders, and one of the women on the call noted that a family of West African immigrants here in New York had lost 30 members of their family, extended family, and that kind of loss, that number is just hard for any of us, I think, to wrap our heads around. I also want to name the fact that it's now well documented, there have been hundreds of clergy fatalities in the United States related to the pandemic. Some of those individuals exposed in institutional or clinical settings, but many are just congregation leaders that were exposed at some point in time in their day-to-day ministry and interaction with parishioners, and later succumb to the virus, as well as those that have been infected and experienced long-term health effects related to that infection. So as we continue to confront the virus, we also are living through its evolution. And presently, there are at least 3 known new strains of the virus in the United States, which present challenges that are just now becoming evident, which, and I'm sure you've read about it, which is that the virus is likely something that's not going to simply go away at some point in time, that this will be a chronic seasonal virus that we have to deal with, just like we do with regular seasonal influenza, even though coronavirus is about 3.5 times more deadly than seasonal influenza. And the new strains are, of course, more virulent. They spread faster, although they're not more deadly. So part of our role is to restore to whatever new normal there is, a balance between physical, mental, spiritual, and emotional well-being, and the toolkit talks about this at great length. How we also serve to identify and mitigate some of the effects caused by COVID-19, including its effects on those of us who already struggle with mental health related challenges and spiritual challenges in the face of this kind of loss, grief, trauma, and adversity. The manual also seeks to help us how to identify signs and symptoms of distress and make appropriate referrals to mental health practitioners. The challenge with that, of course, is that most of us in day-to-day ministry tend to refer people to mental health services for typical stress reactions to things that are going on in their life or mental health disorders. But finding someone who has an expertise in trauma and has an expertise in complicated grief is not always that easy. And doing mental health interventions currently means for the most part, for most of us, it's not face-to-face, it's virtual. And that is a new kind of support for many of us, even though we've been living with the pandemic now for just about a year. We're just a few weeks short of when parts of the country started going on lockdown and services started being offered remotely. So the table of contents includes calling on faith and community leaders to engage with pandemic mental health initiatives. What is mental health by definition, and why does it matter? How to support mental health during the crisis, how to support mental health year-round. So there's some content that's considered what we call evergreen, so it's always relevant no matter what the hazard is. There's some other details about biographies and resources as well, which we'll review a little bit of. I also want to name these aspects of the toolkit for those of you that are interested in some of these topics that we're not going to be covering in the webinar today, which is basic terms and definitions around mental health, crisis mental health, moral injury, grief, complicated grief, funerals, self-care, although we are going to touch on that, how to support mental health resilience year-round, and a mental health action calendar. Just going to read through some questions quickly. Paula, I'm certainly sorry to hear about your loss.
Thank you.
So, apologize for the grainy picture. High resolution cell phone cameras weren't available 20 years ago. So this is an image of Pier 94 in New York City, which was the original Family Assistance Center for 9/11. And I put it up there because it's indicative of some of the early chaplaincy work in disasters that I did personally. And there are some stories that I think are relevant to what we're talking about and what we want to talk about. One is a woman who saw the planes hit the Twin Towers and immediately couldn't really function any longer. She was the kind of life of her congregation. She was somebody who was already widowed but had an adult daughter and just began to kind of fade away from her life, a vibrant extrovert that she was. And coming across her story, for any of you that have seen it in the mental health first aid curriculum, I think was very telling of a lot of what I experienced at the time, which is some people really started to change who they were at their core, and they couldn't see it for themselves until their loved ones around them were able to name it for them. And even then, it became difficult for them to figure out how to climb out of the depression, the anxiety, and the grief that they felt. There's another story I have of a young father who came into this facility early on and spoke to one of my chaplain colleagues who said that he was there because his son made him get out of bed and come because he hadn't been out of bed in 2 weeks. And the son being a small child, like an 8-year-old kid, so not somebody who we would, identify intellectually as being an adult. But this father was only able to kind of motivate after someone who he deeply cared for felt like he wasn't being a good dad anymore. And what was it going to take for him to find help? And this was the only place he thought he could go to find help, was to come to this assistance center. So again, in some cases, people are seeking help through their congregation and through their family, and others are going to seek out professional help in different settings. The question is, can we help be a part of that process? Can we help people figure out when things aren't normal any longer, and when we can help them kind of connect with professional services, but also how can we help empower those around those who we care for, those who we're responsible for, those who we pastor, to identify changes in the people around them. And some of it is not necessarily about death or dying. Some of it is around anxiety and stress. The CDC's new advice that came out a couple days ago that wearing 2 masks reduces your risk by up to 95%. And I got on the phone that evening and my mother, who's 93, said, "Do I have to start wearing 2 masks now?" That, a legitimate question, but my mother, we don't allow my mother to leave the house very much. So, my advice was, I don't really think you need to wear 2 masks unless you're going to a doctor's office and you feel like that's what you need to do. So I want people to make informed choices, but we shouldn't make choices based on fear. We should make choices based on sound science. So mental health during the pandemic, pre-COVID, we know somewhere around 16 to 20% of the American population already has pre-existing medical challenges related to their mental health. That can be anything from chronic health illnesses like depression or schizophrenia, or it can be episodic things, right, like seasonal affective disorder or any other kind of temporary stress or trauma that we experience in our life. We also know that there are profound mental health inequities in our society. Depending on where you live, how educated you are, what your race is, what your sexual orientation is, what your income level is, or what your poverty level is, all of those things present as inequities in our society. And those inequities make it harder to maintain our health and harder to access help when we need it. There's a legacy of discrimination and racist violence in our society that leaves some communities more vulnerable, more traumatized, lacking in trust. And socioeconomic disparities that continue to plague our society that make it just impossible for some people to figure out how they can afford help even if they know they need it, or how to afford medications even if they know they need it, or have already been prescribed those medications. COVID-19 amplifies all those pre-existing realities. It increases our stress level, and it creates hypervigilance, as I was talking about with my mother's comment. Every time there's new information, we are pivoting to decide whether or not we have to react to that, and what's it going to cost us to react to that. And for some of us, it's scary. Every new piece of information is scary. When we hear there's new variants and those variants spread faster, and all of a sudden we need 2 masks, and one vaccine is more effective than another vaccine, but I can't get the stronger vaccine because the sites that are delivering that are backed up for weeks. So everything is a new stressor as we navigate the process. And I'm sure, as you're already very well aware from your own ministries, anybody who's under stress and has experienced trauma or is grieving already has a high stress level, a high anxiety level, and is in some period of grief, and perhaps complicated grief. The decreased access to care has been also a major challenge around mental health. There are a lot of people, some of us may be among them, who simply choose not to do things that they know they should do because it just adds additional risk. So I know I've gained weight since the beginning of the pandemic because I refuse to go to the gym because I think gyms are risky. I live in New York City, where in every gym, all the equipment is like 2 inches apart. So in other parts of the country where gyms are much more spread out and they put partitions between equipment, maybe it feels safe, but it doesn't feel safe to me. So the consequence is gaining weight. And that adds stress as well, and it is not healthy. That shouldn't come as a surprise to any of us, right? The more weight we gain, the less healthy we are, the more risks to our health there are. Losses are, in addition to the loss of family members, Paula has mentioned losing her husband. I have lost 2 members of my family. I'm sure others of you have lost members of your congregation or family that you loved and cared for. And that, of course, is a loss that we feel deeply. But the loss of tradition, the loss of community, the loss of touch, of intimacy, of corporate worship, of singing, of shopping, and I don't recommend lots of shopping, but shopping does bring happiness to some of us. Even just leisurely going through the grocery store or going out to a meal, those are all losses that complicate the deep pain of human loss and lost intimacy in our relationships with others. And then we have the effects of altruism and heroic response. It's great to see all the wonderful people out there that are helping in the medical profession, in the mental health profession, the military, in our government. There's lots of people trying hard to fight the pandemic. And most of us feel better knowing, assuming we have confidence in that leadership, about the fact that there are people making decisions for us and helping and leading, trying to make it better. But with every setback, we also fatigue of the supposedly good news because there's almost just as much bad news. So I'm sure some of you, if not all of you, have seen these graphics before in your chaplaincy trainings, but where do you think we are during the pandemic right now? If you want to comment, you can unmute. From the graphic on the left. Are we preparing? Are we in response? Are we in recovery? Are we in prevention? Or all of the above?
I think it seems like we may be in the mitigation stage as well.
Yeah. Right, we're still doing a lot of prevention, right?
Right.
And we're not necessarily all exposed yet. So there were communities up until the second wave, certainly here in New York, upstate, that had never had a single infection yet. They didn't get those infections at all for the first several months of the pandemic. But all of a sudden in the fall, they started getting infections. So for them, they were just always preparing, and now they're in response. And nobody's recovered, right? Even if you've had it, I had the virus in March. I don't have it anymore, but I haven't recovered. Our economy hasn't recovered. We're not moving forward as a society yet. We're still trying to evaluate. And so when you look to the left, depending on who you are, where you live, and how the pandemic has affected you, you can be anywhere along this spectrum up through trigger events. So for me, I was a lucky one, and I got infected around March 13th last year. So before we even went on lockdown, and I know exactly where I got it, I went to a fundraising dinner, and I knew I shouldn't have gone. Like, I knew this science was going to come out that these kinds of events shouldn't be attended, and I went and I got it. And now I won't even go to any of those kinds of events, right? Even though I've had it and the chance of getting it again are very, very limited, I won't go to group events, right? So for all of us, it's different where we are in this process, but I want to then name the fact that we have multiple threats. During this pandemic, we not only experienced normal life cycle reactions to the pandemic, but we've had other events take place during the past year, including the George Floyd killing and the Black Lives Matter movement and protests that evolved out of that, all of the election cycle violence and narrative that went on for almost a year going into the election, and all the stressors of watching that unfold in our country. There were also several very serious hurricanes that hit the mainland last year, wildfires in California. So we have this complicated reality that our nation faces. Even going into 2020, there was all the, I'm sure you all saw the memes and comments about, 2020 being like the annus horribilis for the world, and we all were looking forward to 2021. How much has changed since we hit 2021? Not a lot. I mean, we have a new president. Was the vaccine instantly more available? No. Are the death rates still disturbingly high? Yes. So we are not just facing one threat, and nobody's grief is as simple as what's going on related to the pandemic. We have to look at what's happening more broadly than that. Okay, we're gonna put up a poll. Who's doing that, Susan or Gabrielle? There we go. So hopefully you can click on this and just share with us. This is anonymous. We're not going to be able to see who clicked what. On a scale of 1 to 5, how stressed are you feeling today? Not stressed at all. I want to be you. Slightly stressed, moderately stressed, rather stressed. Now, how much of that stress comes from what I'm sharing? that reality as well. So really, 80% of us have some moderate to high levels of stress. And we're sitting at home. We already had our coffee. And we're with colleagues, we're with friends, we're with people who we know are skilled caregivers. Feeling anxious and lonely, sad, these are all common reactions, right, to the conditions of physical distancing, isolation, and quarantine. And what's acute stress? Symptoms of stress that continue for a significant length of time, and usually, on average, something that continues for more than 2 weeks. Well, we've been in this pandemic for how long now? 50 weeks? We can all agree that's more than 2. I can assume that, right? So 50 weeks of vigilance, or in some cases anger. There's a lot of people angry in the United States that think the pandemic is fake news, right? That it's overhyped, that it's political in some cases, or that might be a little bit too simplistic for some. Some of us believe that the pandemic is just sort of a natural course of a virus, and that we've overreacted by closing down our society's economic drivers to the extent that we're not only killing people, but we're also killing our economy, right? They have a more practical view that says the economy matters just as much as life. We can argue about all those things over lunch someday, but those are the realities, right? We have many different opinions about what we're going through and why we're stressed about it. The symptoms of stress are magnified in acute stress and experienced most of the day. Now, for those of you that leave home and interact in a variety of settings where you're constantly trying to remember whether or not you have your mask, when you washed your hands last, you look every time you enter the grocery store for a hand sanitizer dispenser or sanitary wipes, or don't touch me, or you're too close to me, or you're gonna walk past me and I see you don't have a mask, or you're yelling at me because I'm wearing a mask and you're too close to me and that's freaking me out. All of those things, that hypervigilance brings on acute stress. And the symptoms of stress begin to affect our ability to care for ourselves or be in relationship with others. We will avoid going out if we think that we're going to be confronted by risk. And we'll avoid interacting with members of our congregations that refuse to wear masks. And then we wonder whether or not we're being effective caregivers or pastors to those individuals based on how they feel and how they live in the realities of the pandemic. The signs of traumatic stress, so different than acute stress, but brought on by trauma: panic, consistent hypervigilance, which is something I've mentioned before, re-experiencing traumatic events. So for someone who is 100, they might remember the 1919 pandemic. That's not many of us. But how many of us have gotten a really bad case of the flu before, or we've lost a relative to the flu, or we've lost a family member to the coronavirus, or we were involved in the Ebola response, or H5N1 or H1N1. So we have distressing memories about those losses and the risk around those losses. Losing touch with our surroundings or memories is a sign of traumatic stress. Difficulty sleeping or concentrating. Difficulty sleeping, by that I don't mean not sleeping enough. I mean sometimes sleeping too much. Feeling more irritable than usual. How many of you noticed that you have friends and parishioners on social media that you didn't realize how strongly they felt about some things when you watch what they've written? And in some cases, very disturbing. How comfortable they are with racism, sexism, anti-vaxxer comments. Politics, of course, have been roiling our country for a long time, and they're still ongoing. So all of those things sometimes are making people react more angrily than they normally did, or they've just never felt free to express that. But now, since they're stuck at home, the only outlet is typing it into Facebook or Twitter or Instagram. Or the Karen syndrome. Is everyone familiar with what that word means? Karens and Kens. These are people who have been videotaped acting very badly in public, sometimes harassing other people or even violently attacking other people, including over things like whether or not people are wearing masks or they're not being allowed to shop because they're not wearing a mask. Are we seeing people who are becoming withdrawn, avoiding reminders of this experience and finding themselves unable to take pleasure in anything or anyone? They're just turning into Grumpy Cat. And do we all know when we're sort of in over our head? So some of us have stopped talking about politics on social media. Some of us have started. Some of us know that we're in over our head already, but we're just trying to survive because we think we see the light at the end of the tunnel. But how long have we been trying to convince ourselves as pastors and caregivers that we've seen that light? Because we all wondered last April whether or not things would be okay by this summer. And then this summer came and we didn't really have a summer. And then we started hearing about the second wave in the fall. And then we thought we would be over it when it was just past Christmas. Then the vaccine came and we thought it would all be over relatively quickly. And now we're hearing that the vaccine probably won't likely help the United States reach herd immunity till the late summer or early fall. That's 2 years of changing our lives away from the routine community that faith communities thrive in. Face-to-face worship, gathering, tradition, worship, ritual. And are we in over our heads in navigating that? How many of you are sort of sick of Zoom worship and can't wait to get back to in-person worship? And you're coming up with creative ways to navigate around rules to get as many people as you can to at least come to hybrid worship. Risk factors for trauma: proximity to sickness and death. Obviously, a hospital chaplain has had a much more painful relationship with death in the pandemic than those of us that work in congregations, because just of the sheer number. I'm sure you've read the articles where chaplains and nurses talk about they have 1 or 2 or 3 people die every shift from COVID, let alone the other things that people normally die from. I used to be a ICU chaplain here in New York City, and it was common for 1 or 2 people a day to die in the ICU. But that's not common in most wards in most hospitals. Multiple traumatic experiences, a history of trauma. Did the George Floyd murder add to the trauma that communities of color are facing in the United States when Black Americans are dying at 2 or 3 times the rate of white Americans? That Latino Americans are dying at twice the rate of white Americans. Now that's happening for a lot of different reasons, but then when you amplify the stressors of that reality on what feels like a counter narrative to racism, is that adding trauma to the experience that African Americans, Latino Americans, other Americans of color are facing during the pandemic? And that's different for each of us, right? We can't answer that for everybody because we're not a monolith, but are we even asking that question of people? When you ask a person of color in your congregation, in your family, yourself, is the pandemic made harder by the racism that is surrounding us in every news cycle these days? And what does that mean to our risk factor for our own internal level of trauma, let alone for those we care for? Persons with chronic medical conditions, older individuals, ethnic and racial minorities. I'll say this from my mother's perspective. She's 93. She's alone at home. Very few people are allowed to interact with her. Nobody goes in the house except for me. She is constantly talking about whether or not it's worth it to survive the pandemic at this point in her life where every day counts because of her age. And is it worth it just to take the risk to interact with people because she wants to be able to enjoy the time that she has left as a 93-year-old? She's probably going to outlive me, but that's where her mind is, right? Because she's not socializing. Secondary trauma. As faith leaders, we may be at risk for secondary or vicarious trauma because we hear it over and over again. We see it over and over again while we're coping with our own challenges, our own loss, our own grief. 4 tasks of grieving. I'm sure you've all seen these before. Accepting the reality of loss, processing the pain of grief, adjusting to a world without the deceased loved one, finding and enduring connection with the deceased while embarking on a new phase of life. How many of you have faced families or your own grief with individuals talking about the fact that they couldn't even have a proper funeral? Right? You couldn't even honor your loved one the way they would have expected to be celebrated and buried. And we, early on in the pandemic, we talked about, well, we'll just wait. We'll do it when this is all over. Well, it's been a year. Might be several more months. When's it over? Like, when do we have permission to have that sort of celebration of life, or gather the community for the burial that we think people were expecting? Pandemic grief looks different than normal because of the frequency and volume of loss. We're not just aware of our grief of the individual that we grieve, whether it's in our family or in our congregations or in our communities, but we're aware of profound, overwhelming numbers of deaths every day, right? 3,000, 4,000 people dying every day of the same thing that's taking our loved ones, our parishioners, our community members. Not being able to be present, of course, is a deeply painful reality. It's that one thing that we can do for someone is help them die with dignity and not die alone. And we're relying on other people to make sure that they don't die alone, rather than doing what we always thought we would be able to do, which is to be with, hopefully, our loved ones when they die, so they know they're not alone. Waiting for remains. I don't know if that's the case everywhere in the United States, but in many metropolitan areas, you cannot get the body quickly. There's just such an enormous backlog in the funeral system that you just can't even get someone buried, even according sometimes to their faith tradition, right? By sundown the next day, or within 24 hours. And it does depend on where you live, right? In some places of the country, that backlog does not exist. And what does it mean to hold a funeral? Who can attend? And lots of people can't travel to attend, even if they're living in a community where they could have a larger funeral than just a graveside burial. And anticipating what this means as we learn of additional deaths of people that we love and care for, including our heroes, right? Many of the people that have died in the pandemic are well-known people, famous people, cultural icons, civil rights icons, famous religious leaders, people who normally would affect us as well because of that special place they hold in our life, even though we don't necessarily know them intimately. Tips for coping with grief to share, of course, with our congregations: accepting loss, talking about loss, taking stock, all the routine things that I'm sure you tell your congregation members and your family members every time there's a loss in their life. But we have to limit, or moderate exposure to the media during this period of time, because this just isn't normal death, right? This is not cancer. This is not a heart attack. This is not old age. This, for many people, feels like it should have been preventable. And sometimes people are trying to place blame for why people have died. And survivor's guilt. A lot of our clients, we have programs supporting individuals that have been hospitalized for coronavirus. They were on a ventilator and medicated and didn't even know their spouse died until they've come off the ventilator and off the medication, right? So their grief is very complicated, and some of them believe it should have been them, right? They wished they would have gone first because they don't know how to cope without that other person. And if it was going to take anybody, why didn't it take me? Or why didn't it take both of us? And then you hear these super touching stories of couples that die together on the same day, minutes apart. And families, some families take solace in that. They couldn't be without each other. We've all heard stories like that in the past. But in other cases, they feel ripped off. The family feels ripped off, right? They lost them both. Being part of the community, advocating in safe ways for grief outlets, and to ask for help when you feel overwhelmed, right? Reminding members of our congregations to ask for help when they feel overwhelmed. Complicated grief is unexpected or violent death, right? So it is complicated when someone leaves the house in the morning and doesn't come home. That's not expected, right? That's not normal. Dying in old age is normal. Knowing that you're going to be taken by cancer sometimes is normal. But these kinds of things are not normal. When you go into the hospital, normally you don't die alone, even if you're going to die. Close dependent relationships to the deceased person complicate grief. It's hard to be a griever and a caregiver at the same time. You all know this. It's harder the closer that person is to us, right? Our spouse, children, parents who live in our homes with us, right? That intimacy complicates things. And the social isolation from the normal support. How many people today get brought a casserole and they throw it out because it's not even worth the risk of opening it up, even though that's a normal part of the way communities share in someone else's grieving process. The past history of depression, separation anxiety, traumatic childhood experiences of abuse and neglect, and the other major stress factors in someone's life. Now, this is the most popular topic for caregivers. I know it's your favorite, self-care. And are we doing a good job at it? Why is self-care important? How aware are you of your own level of compassion fatigue? Are you honestly taking the time you need? I had a clergy person on a Zoom this week who talked about the fact that they told their congregation they had to take a week off and they weren't doing any Zoom worshiping or anything. That was it. They kind of hit their wall. They were making an announcement. It was non-negotiable. How many of your vestries, councils would be receptive to that emphatic statement? I'm done. Taking a week off, like it or not, walking away, deal with it. Perhaps not that gruffly, but how many of you would love to do that? Be honest. You don't have to raise your hands. This is being recorded. what might be some barriers to our own self-care? Some of them being practical and some of them not, right? What kinds of things can you do after dealing with traumatized people to take care of yourself? And who can you count on to talk to after having a difficult pastoral conversation, other than family or friends, right? This can't just be about relying on family. But how many of you have accompanied someone in death before and felt good about that because that's your role? You were there for them. They passed away in your presence, surrounded by loving family, and that's not depressing. The loss, of course, is something that we mourn, but you feel good about that, right? I always, particularly when I was a hospital chaplain, I always felt good at the end of the day if I had been with patients who died and had helped families through that process, that sort of dignified death. But how do we take care of ourselves when we know that's not really what happened in this situation? That it wasn't, that it wasn't a helpful way, a helpful experience for the family or the individual. Self-care. We're going to have a little poll here. Again, this is anonymous. Nobody can see who answered this, including us on the back end. How many times a day or a week do you spend time practicing self-care? And I realize some of you might be very loosely defining self-care. Okay. %40 of us are doing it almost every day or every day. That's pretty admirable. For those of us not in that 40%, we can respect that. It's a goal to aim for. I think we all know that less than once a week or 2 or 3 times a week is not enough. Can we agree to that? And what do we mean by self-care? Eating a pint of ice cream every day? I think we know that's not really self-care, if we're being honest. Exercise, prayer, spending time with our pets, art, singing, I mean not in church, outlets that help us emotionally, physically, help maintain our health. Substance use is not self-care. Substance abuse, obviously, is not self-care. So I hope as we all assess our attempts at self-care, we're being honest with what is self-care, what is healthy, and what is not. Pandemic safety practices are good self-care, right? We want to stay alive. Care for our bodies, to move and stretch. How many of you sit in your Zoom captain's chair too often every day? I know I do. Most days I sit in this chair most of the day on Zoom meetings. Move and stretch, connect with loved ones. It's hard to do that other than who lives in our house with us. And delegate as much as you can. I'm sure my staff think I delegate too much, and I don't think I delegate enough. But also not allowing, giving ourselves sort of permission, I would say, to speak about our self-care with those who are responsible for our ministries. For those of you, I don't know if any of you on this call are Episcopalians, but the Episcopal Bishop of Louisiana, following Hurricane Katrina in 2005, had to take early retirement because he developed such a severe case of PTSD in the first couple years after Katrina. There was just such profound loss of life and property, the complete change of the city. And for a bishop, and Brennan, I'm sure, can relate to this, for a bishop who is a shepherd for many, to not be able to be an effective shepherd as a result of the burden of ministry is a failure of the church above that shepherd, to not be on the lookout for signs and symptoms of distress in that ministry. And for those of us that are simply shepherds of a congregation or a staff, the boards above us, the vestries, the councils above us, it is their duty to check on our well-being and to make sure we are intentional in taking time for ourselves. And so we have to model that sometimes. And we also, I think, need to give ourselves permission to talk to those who do technically govern, at least with us, if not over us, that we're not getting the support that we need from them, and to name what we need. I think the Lutheran Church did a very interesting thing in New York City after 9/11, where they mandated clergy take a month off with their families, and they got Lutherans from around the synod to donate vacation homes or funds so that every pastor could get time off with their family for a month. This was after the intensive cycle of funerals that followed in the wake of 9/11. That's a pretty impressive decision for adjudicatory to make, noting the stress that their pastors were under and instructing them. It wasn't optional, by the way. It's not like you can do this if you want. It was that you will do this. And knowing some of those Lutheran pastors, it was met with resentment by some, and gratitude by others in the beginning, but when they all came back, they were glad they did it. How many of us have ever, other than sabbatical, really taken that time off after a major stress event in our lives? So suggestions to incorporate in your daily life. No surprises here. Limit your exposure to news about the pandemic. In general, stay off Facebook. That Facebook is probably the most toxic place, but Twitter is sort of right behind Facebook. Simplify and streamline your tasks. Take time to read or exercise or sit still, be prayerful, garden, whatever. Maybe not now during the middle of the winter, but when you can, those things that you find help you still your mind. Be gentle with yourself, be patient, even when you aren't doing things well, right? We all think our last sermon was our worst. It rarely is, though, right? There was one way worse. We just don't remember it. We But even for those of us that generally are used to being exceptional preachers, we still are hard on ourselves sometimes and wish we would have done it differently. Share in the chat or unmute how you've been practicing self-care throughout the pandemic. And as a secondary question, what policies or practices have you put in place to encourage self-care amongst your staff or your congregants? I would add your clients, depending on the setting that you're in.
Well, for me, I'm pretty good about if I'm feeling stressed or I'm feeling the weight of the loss of my husband and experiencing my grief and working through that pain of kind of going off to myself. I do live alone, but I have a really good support system with my family and friends, and they're very good listeners. So I do take the opportunity to either vent in my private time during prayer and meditations, or just whenever it starts to pop up and I start to feel stressed, I give myself permission to kind of ventilate and let that out. But it's amazing how my friends and family are kind of intuitive to if I'm heavy on their heart, they'll call me. And there have been many times when I've needed a person to verbalize what I'm feeling, other than just expressing it through pain or anger. I have my husband's baseball bat, and 2 times I've picked up the bat and just started slinging it in the house, on the furniture, the cushions, the bed. But the other night I just wanted to smash everything in the house. And I know that the rule is don't harm yourself, don't harm others, and don't destroy property. And so I just beat the heck out of the cushions on the couch and the bed. And then my niece called, and while I was crying and kind of coming out on the other side. And because I was able to verbalize that, it literally released all the pressure, because I was supposed to be going to her house to celebrate my birthday and my twin sister's birthday, and I was not feeling it. So part of my self-care is to be aware of the grief that's coming up, and to give myself permission to express it, but also to give myself permission to kind of pull away, spend quiet time. If it's just sitting in the chair, closing my eyes and focusing on God and focusing on His comfort, Him being there for me to comfort me when I'm alone.
Thank you, Paula. Would anyone else like to share? You have to unmute if you do, by the way.
Peter, I'll share something. I was actually reading this morning and I just think modeling it or being an example to those that we care for is important. And I was reading something about Gandhi this morning, and about a story of a woman that came to him, had walked 4 miles from her home to talk to him, and needing his help with her son, who was obsessed with sugar and candy. And she wanted him to tell her son to stop eating this candy and to really take more care of himself. And he said, well, come back in 2 weeks, which made her very upset about the fact that she had walked all this way and took this time, and he wasn't going to help her at this time. So she came back in 2 weeks, walked all that way again. And she said, look, he's still obsessed with candy. He's still eating sugar. He's not taking care of himself. And Gandhi, looks at him and says, son, it's bad for you. You need to stop eating it, and it will change your life for the better if you do. And she says, well, why didn't you tell me this 2 weeks ago? And he says, because I knew I needed 2 weeks to stop eating candy, which I love to eat, myself, and I couldn't ask somebody else to do something I was not doing myself or not prepared to do for myself. And I just, that struck me very, strongly, like, yeah, we need to be doing these things for ourselves and taking that time and that space to make sure that we're connected with the Spirit, that we're connected with the Lord, and that we're prepared to serve and help those that may be in need. And it's just vitally important to do what we're doing out there. And a lot of it is asked of us, and that's why it's so important that we just take that time.
The old line that people used to tell us of "do what I say, not what I do" doesn't really work well for those of us in caregiving roles, does it?
Yeah.
Anyone else? Okay, thank you. So let's talk about referral. This is definitely a challenge, I think, for all of us. Finding the right person to refer someone to often feels very burdensome. There's a lot weighing on us when we recommend someone as a caregiver for someone that we're responsible for pastorally. During the pandemic, that's made even more challenging by the fact that therapeutic settings are often remote these days, and that is even harder for people to, I guess, harder for them to like, especially if you're new to therapy. So symptoms of stress, again, that continue for at least 2 weeks or longer. We can all agree that stress is normal. Perhaps this is such an abnormal kind of stress during the pandemic that duration can even be looked at differently than 2 weeks. But you can't not eat for 2 weeks. You can't not sleep for 2 weeks. So 2 weeks is usually a good indicator where there's a lack of healthy adjustment to whatever is going on. So symptoms of stress are magnified and experienced most of the day. I would put it this way: if you spend your day thinking about the pandemic and thinking about your safety, the pandemic is taking over your life. If you spend your day, most of your day, trying to navigate a loss, it's beginning to take over your life. It's normal, obviously, to think about your safety or loved ones, but not most of the day, not 2 weeks later. It's not normal to get angry enough to scream at people in public. It's not normal to stop paying your bills. It's not normal to abuse alcohol all day long, or all the other things that we talk about when it comes to symptoms of stress. You've all heard the term, I'm sure, live, laugh, love. When the stress in our life is affecting our ability on a day-to-day basis to live a normal functioning life, to laugh and to love, particularly those who we're also responsible for, we're definitely getting into the realm of needing some help to figure out how to navigate that. Now, sometimes sitting down with a friend and just having a discussion is enough of a reset button for most of us, but sometimes that's not. Sometimes we do need to talk to someone else. And that can be a pastoral counselor, that could be a psychotherapist, it could be a psychologist, it depends, psychiatrist, it depends on what symptoms are presenting. So, emotionally and spiritually vulnerable population, those who are unheard. I would add in the pandemic to those who are isolated. if you're socially isolated and isolated from family, you are vulnerable emotionally. Those with pre-existing mental health challenges, those dealing with substance misuse and addiction, those who are socially or historically marginalized, and those who are experiencing racism, racial inequity, phobias, and isms of all kind, for that matter, gender bias, trans and homophobia. Suicidality has increased as a result of the pandemic. I'm sure you've all read about it. Suicide rates, suicide attempts have skyrocketed, particularly amongst young people. Here in New York City, the highest suicide rates in the city are amongst Latino girls in their late teens. Lots of different reasons for that, but a very disturbing trend. And it's actually been going on for a couple of years, but it was amplified by the pandemic. I think we can all agree our high school experiences would have been different if we couldn't go to school, right? If you were told when you were 16 years old, you're gonna have to start staying home 3 or 5 days a week and going to school. There were no computers when I was in high school, so I can't really relate to that reality. But if you were told that you were going to be isolated from your friends, you couldn't go to their houses, you weren't going to have prom, you weren't going to have football games, you weren't going to do all the normal stuff that you look forward to as a teenager, and you're emotionally immature to begin with at that age, how would you react to being basically locked up with your parents and siblings for the next 12 months of your life? I can tell you, in my case, it would have been extraordinarily challenging. Some people, I'm sure, navigate that quite well. Their family dynamic can survive that. In most cases, I can't imagine it's been an easy time. I'm sure for those of you that have children or grandchildren, you've heard lots of different opinions from the adults in their life about how well remote schooling is going. How about college, right? Would college be normal if you spent your entire day in your dorm room and were given 15 minutes to eat in the cafeteria between plexiglass partitions and there was no real social life? These are the realities that young people are facing. And then the reality of people like my mom, who thought that by the time they were in their 90s, they would just be surrounded by loving family and doing family events and celebrating births and baptisms and weddings and hanging out with your friends and enjoying the life you have left to live, and then be told, well, just sort of suspend that, you know, for a year or two while we wait for the pandemic to finish, and maybe you'll live beyond the pandemic. That's part of our reality. Reluctance and barriers, fear of provider bias, a lack of cultural or religious competence in mental health professionals. This gets expressed really regularly in a lot of our chaplaincy trainings. A lot of clergy don't believe that mental health practitioners understand the faith and beliefs of the people that they send to mental health care, or they don't respect their belief system. And if you are a person of faith, can you be effectively cared for by someone who doesn't respect or understand your faith? I think that is a major disparity in the provision of mental health care. Loss of control, loss in the system, if you will, a perception of institutionalized care, a perception of lack of safety, a perception of actual risk in institutional care. What about if you know you're schizophrenic and you know you need to go spend some time in a hospital and you know there's a pandemic, schizophrenia has nothing to do with intelligence. You can be brilliant and be schizophrenic, but are you going to go into care? Or if you are a substance abuser, if you know you need to go back into treatment, are you going to seek that residential treatment during a pandemic? Or do you just see that as the lesser of two evils? I might as well just wait until the pandemic's over. Does someone who's an addict need that kind of an excuse not to get care? I can't, it's too risky right now. I'm just going to wait until the pandemic's over before I treat my substance abuse. Diminishment evaluation of one's role as a faith leader is something none of us can afford to do. I can do this, the unwillingness or inability to acknowledge limits of one's knowledge. This is probably a mistake more made by young clergy than experienced clergy, but sometimes what people need is well beyond our skill set. I would put it this way: just because you went to medical school doesn't make you a neurosurgeon, and just because you went to seminary doesn't make you a good youth minister, right? There are specialties in this business, and we do have to know what the limits of our own abilities are. Is the person that we're working with, or ourselves for that matter, part of a vulnerable population? Do we know that? Can we name that? Where are they in that disaster life cycle we looked at before? Are there good reasons for them to be stressed? Good is probably too much of a value judgment word, but are there appropriate reasons for someone to feel stressed? How long have those stressors been evident? And let's remind ourselves that signs and symptoms are hard to determine. Signs are something that we can see. Symptoms are something we have to explore. We have to extract from someone. We have to get them to admit. Hard to do remotely, much easier to do face-to-face. Our skills of observance are diminished by remote interaction. You can stick yourself in a clean corner and turn on your Zoom, but if you asked a parishioner to turn that Zoom camera around and show them the condition of the room that they're in, would you get a different perspective on their health? What are called like Zoom pants, right? From the head up, you're wearing what looks like an appropriate clean shirt, and from the waist down, you're still in your boxer shorts when you get on the Zoom in the meeting in the morning, or sweatpants, or you're unprofessional from the waist down. Is there concern in their answers or behavior that are causing concern, and can that be confirmed? I do think we have to sometimes confirm whether or not our observations are correct when our observations are limited. I can't smell alcohol on someone's breath through remote pastoral care. I can't see that the room is full of dirty clothes or pizza boxes or beer cans, or that their children aren't well bathed or well dressed, or that the kids aren't even on their Zoom classrooms when they're supposed to be. So are the people we're caring for actually caring for those they're responsible for? Those are all things that limit our ability to observe when we're remote. Is this normal stress response, or is it acute stress response? How are you coping, right? What is not going well? What are you missing? What do you need right now? What do you need from me? Have you passed a tipping point in your behavior, and are you doing something that you don't that you haven't done before? All of those are legitimate questions to ask somebody, and they become all the more essential when we can't interact face to face. We can all accept that people tell us what they think we want to hear sometimes. When you're in trouble, you turn into an adolescent sometimes, and you hide the truth from people that you think are going to hold you accountable. What's not going well is a hard question to avoid answering. It doesn't give you an easy exit from that question. What are you missing? Also, is not an easy exit question. You have to answer into something that makes sense. And we know when where someone's sort of giving us fluffy answers. Is Paula missing her bat? Sometimes, right? What would happen if someone took all the pillows? What do you need from me? And can you articulate that is an important sign, right? Can you articulate what you need? And some of it's just like, I need to see you. I feel like I'm disconnected from you as my pastor because I just see you on TV, right? I just see you on the computer. And how can you say to somebody, well, if I come by today, can we take a walk together outside? Because I'm not going in your house, right? But can we take a walk? Have you passed the tipping point in your behavior? We all know what it means to ask people to make promises when they discuss things like self-harm. You know, we're going to continue talking about this, but you have to promise me you're going to call me if you ever feel like you're going to harm yourself, or if you start planning for how you might take your own life, you're going to give me a call. That's our commitment to each other. Because if you can't promise me that, I don't know that you're safe, and I have to make sure that you're safe. Like that's my responsibility. So have you passed your tipping point, and do you promise me you're being honest with that? And you promise if you do reach your tipping point, you're going to call me. And what does your tipping point look like? Because sometimes you learn that someone's passed their tipping point because they've already named it, right? One more day with this kid at home with me, and you know, it's gonna be an ugly day, and yet tomorrow you know that their kid is back on remote learning, and you've got to make that phone call. How are you feeling about the fact that your kid's home again today? Are you doing something that you haven't done before? To me, this has been one of the most interesting questions that I ask as a chaplain, particularly in mass care settings post-disaster. Like, what are you doing now that you didn't used to do? And sometimes I think people have come up with really brilliant coping mechanisms that are helping them through the crisis. And sometimes people name things that you know in just naming them is a cry for help. I'm back to 2 packs a day, or I'm stopping at the bar every day after work, and I only used to do that on football night. I'm not showering anymore. I'm not paying my bills. I can't even get out of bed, and I used to get up every morning and run 6 miles. That is an extraordinarily telling question in our assessments. How to refer to mental health. I will say this, every county has different referral systems that are available, and obviously you have your own professional networks, but as a rule, you want to inform the person that you're concerned, and name specifically why, in this case, you think it's relevant to the pandemic. And this, I think, is the most concerning part of the pandemic. News changes every day during the pandemic. Almost every news cycle is new information, and rarely is it better. It's just new. It's a new threat. It's a new failure. It's a new problem. It's a new death count. It's rarely someone getting on the news and saying, tomorrow there's going to be 500,000 more vaccines in our state, right? So as a rule, inform the person you're concerned and why, relate it to the pandemic if that's appropriate, let him or her know that you care for them. This is all routine stuff that you've learned and practiced, I'm sure, over the years. If you have an option, you should present different possibilities for what's next for that person, and discuss what support systems are available, if there are some available, and assure the person that you'll continue to support them until the referral is complete. Harder to do these days, right? It certainly was common for me to previously say to someone, we're going to get some help and I'm going to go with you the first time if you would like. I'll go with you to your first AA meeting if you would like. Today, that's not necessarily something I would choose to do if I could, but I might. It depends on the setting, it depends on the person, depends on the extreme distress that they're in. But if I can't do it, someone else can, right? And so helping someone navigate that sometimes is necessary. If I can't go, we need, you know, someone who you trust to go with you. So lots of opportunity for Q&A here, but we're past our time, but that's okay. And I'm happy to stay and answer any questions, but I do want to quickly burn through a couple resources here. We do have these tip sheets available. You're going to get a copy of the PowerPoint so you can get these links. Always remember the Disaster Distress Helpline, which is free. It's available by phone in 160 different languages. You can also text the Disaster Distress Helpline. It is funded by the federal government, but it's actually operated by a nonprofit called Vibrant Mental Health. The National Suicide Prevention Hotline, the National Domestic Violence Hotline are always a resource. Remember, you can always Google these things, or you can have these numbers in your phone. NAMI, the National Association on Mental Health, also has support text and phone numbers as well. And the National Helpline for Caregivers, that's you, by the way. And obviously colleagues in ministry. There is this disaster app that we've created over the fall that is offers information on religious literacy and competency for caregivers who are unfamiliar with various faith traditions as well. We are going to send you an evaluation. I implore you to fill it out so that we will then send you the PowerPoint. But that is going to come from Susan, and I'm happy to answer any questions that you have.